Dear colleagues, I would like to welcome all of you. You were 500 participants to register to this webinar. The ENS and the skill-based sections are very happy of such a huge attendance. We have the chance to bring together with us this afternoon 3 experts in endoscopic procedure who will discuss the advantages and disadvantages when using endoscopic assisted techniques to handle CP angle pathologies. Dimitrios Paraskevopoulos is a consultant neurosurgeon based at Barts and the Royal London Hospital in UK. Dimitrios Paraskevopoulos will talk on basic concepts and technical feasibility of CP angle endoscopy. The second lecture will be given by the Professor Henri Schröder, who is professor and chairman at the Department of Neurosurgery at the University Medicine in Greifswald, Germany. Henri Schröder will discuss with us the place of the endoscope in the management of trigeminal neuralgia, hemifacial spasm, epidermoids, and vestibular schwannomas. Finally, the third lecture will be given by Professor Sébastien Fröhlich, professor and chairman at Lariboisière Hospital in Paris, France. Sébastien Fröhlich will speak on endoscopy used as complementary adjunct in some skill-based procedure. Before giving the talk to Dimitrios Paraskevopoulos, just if you have any question, please use the Q and answer button and we will respond to the question at the end of the webinar. So please, Dimitrios, it's up to you.
Thank you very much, Michel, and thank you for the opportunity to be part of this webinar. So I'm going to start sharing my screen now. And I'll try to give an overview on the application of endoscopic techniques in the CP angle, hopefully in a sort of measured, balanced approach as to what is technically feasible, some of the indications which will be covered later on more extensively by Professor Schröder, and some techniques and limitations. We'll try to take a look at some evidence or the lack of evidence, if you like. Most of the evidence so far is published series, and I think that is to be anticipated. And hopefully we can prompt an interesting discussion on why to use or why not to use endoscopy in the CP angle. There are some basic prerequisites in order to start doing endoscopy in the posterior fossa. Obviously, the first one is the equipment. You need some basic equipment like the endoscope stack and the camera and the endoscopes. These are known from transsphenoidal and intraventricular surgery. The progress in optics and full HD cameras has been amazing over the last 10 to 15 years. The second prerequisite is the learning curve, and we'll take a look at that towards the end of this talk. In terms of equipment, the different endoscopes one can use, and sometimes this might be up to surgeon preference. You can use a 2.7 millimeter or a 4 millimeter diameter endoscope, and it would be interesting to see what the other speakers in the panel use later on. You can use straight endoscopes like the ones that often are used for transsphenoidal surgery, or you can use an angled camera, which is a different type of grip and might be more ergonomical for specific freehand indications, for example. When using angled endoscopes, you probably need to use angled instruments. There's no point in trying to work around the corner and see around the corner if you don't have angled instruments available. Then we'll talk a little bit about holders and assistants and freehand or bimanual technique. What I found very, very useful in the last few years is utilizing single shaft instruments like you see in the pictures, and then you have a bit more space to work. And what I also find useful is using a malleable section, and we'll see towards the end of the talk a video utilizing this trick. There is an abundance of bipolars in the market. Most of them are not custom designed for this application, obviously. So personally, I started off using the normal bayoneted bipolars. Then I did try to use the take-apart bipolar, which most of us or some of us may use for the transphenoidal cases, but I didn't find it very useful in CP angle endoscopy. So I kind of reverted back to the normal bayoneted bipolar. There are newer bipolars on the market that have a single shaft and may be interesting options in order to have a bit more space. It is a very tight compartment in the posterior fossa sometimes, and it's useful to have single shaft instruments. In terms of basic concepts, you see here a picture of the 0, 30, and 45 degrees. There are different angle degrees in the endoscopes available, and the whole point is in having the ability to look around the corner, as I said. When using the 45 degree, obviously the angle is much better, but you need a bit of caution when you're introducing the instrument. And when you're using, in my opinion, something more than a 45 degree, then often you need a second scope to be able to introduce it. In my practice, the 30 degree endoscope is the most useful one and the one I use more, but it probably varies with surgeon preference. Having said that, even the 0 degree endoscope provides a little bit of a panoramic angled view. These are known concepts from endoscopy in transphenoidal surgery or other types of endoscopic surgery. And you see you can have a straight view, but with a bit of distortion and the fisheye effect, you can still have a bit more of an angled panoramic view. So you have a wider field just because the image source is very close to the operative site. These are pictures from a very good book on endoscope-assisted neurosurgery, so that's interesting reading. And they depict very well the angle of approach and where you can reach with straight or angled scopes with this panoramic view. And just by rotating your hand, we can see that you can reach a completely different area in the posterior fossa. The other interesting aspect in this picture is that it shows the grip when you're using an angled camera endoscope. So that's a different technique compared to the straight endoscopes that are, in my opinion, more easily fixed with holders. One advantage in endoscopic CP angle surgery can potentially be positioning. I think most of us do most of the retrosigmoid approaches or lateral, let's say, suboccipital approaches in a park bench position, or some of us may be sitting or semi-sitting. In a fully endoscopic approach, one can just use a supine position with head rotation. Obviously, when it's a microscopic operation with endoscope assistance, then I still personally use the park bench position. But what would be interesting to discuss about is the setup. So if you, regardless whether using supine with rotation or park bench, the screen obviously has to be on the opposite side. The holder, if you are using a holder, probably has to be on the opposite side because they tend to be quite bulky and they can be a problem when you're using them on your side, and then you use the endoscope to look into that direction. In terms of incision, most people would do a Lazius or a C-shaped incision for, let's say, a standard retrosigmoid approach. If it's a fully endoscopic approach, one can use part of this incision so that there is the option to extend. However, there is a discussion about the orientation of the incision, and we can also discuss about how we place our retractors, and I'm hoping that Professor Schroeder might elaborate on that a little bit, because I know some people place their retractors differently to facilitate how to insert the endoscope and we have a bit more space. Personally, I usually place the incision cranially centrally or caudally, depending on where I want to go, and I try to make it part of an incision that I can extend if I have to. And we'll see some interesting articles from literature which explain the concept very well. So this is an interesting anatomical study, and it shows that depending on the surgical target, you can tailor your incision to a caudal subtype, a central subtype, or a superior subtype. And interestingly, you can see the position of the retractor. This is not what I personally do, but this position of the retractor might actually be more favorable in a fully endoscopic approach. Equally, in this article, you can see this differentiation between central, superior, and caudal subtype. And you can also see very nicely the setup that I tried to describe previously of where the holder is. I hope people can see the mouse pointer on the screen and where the endoscope stack is. And you can also see this is a technique using the holder. And you see the holder being parked at 12 o'clock, let's say at the apex of a triangle, leaving enough space for two instruments and potentially a retractor. And we'll have a chat about the use of retractors or not. In terms of techniques, there's the freehand technique where the surgeon holds the endoscope with his left, or let's say non-dominant hand, and works with one hand. There is the technique of working bimanually and using a holder or a second surgeon. And there are advantages and disadvantages to both techniques. I think it's useful to tailor this by indication and by the surgical goal, and also by training purposes. If you're trying to train a second surgeon, it might be useful to swap places or to let them navigate the endoscope. In my experience, the 30-degree endoscope is probably the most useful, but obviously there is a wide range. And then we'll have a little chat later on about the difference in technique when working superficial to the nerves and deeper to the nerves. Just to go into a bit more detail about holders, the use of holders can be very useful, but it's still questionable and it still remains surgeon's preference. One thing to bear in mind is that the holders are not task specifically designed. So you can find any sort of holder in the market with different kinematics. You can find robotic holders, mechanical holders, but they haven't been designed specifically for this task as far as I'm aware. And we did try to take a look into the literature and the surgeon's experiences and preferences many years ago. And what we realized is that a lot of the experience is translated from different areas, as one would expect of endoscopic surgery. This is an article in the literature about trigeminal neuralgia, which my colleague will present with videos later. All I want to show here is a little bit about the setup I'm trying to describe with the holder in position and the two hands resting. What I sometimes find very useful is using an armrest or a retractor set like the Doro retractor or something similar where you can rest your hands. And you can see here the concept of this triangle with the endoscope parked at 12 o'clock in the surgeon's view, so at the apex. There are some tricks one could use. Sometimes resting the endoscope on the petrous bone, whether you're using fixed retraction, so whether you're using a holder or freehand, may be useful depending on which area you're trying to aim at. Equally, resting the endoscope on a cerebellar patty, if you are not using a retractor, could potentially be useful, but then this is a freehand technique. You need to move the endoscope, so that's a little bit more tricky. What I sometimes find useful is using a single retractor, especially at the start of the operation. And there's usually enough space to put a single retractor. We'll see some videos later, and that just makes life a bit easier. If you are using an assistant, then the assistant may want to use both hands just to fix the endoscope a little bit better, because it tends to be very shaky, as we're going to see in some videos. But then you need to be very well coordinated between the two surgeons so that there is enough space for both. Caution needs to be taken when the holders go on and off, but again, that depends on what type of holder is being used. Nowadays, there are really nice, expensive robotic arm holders where the drift is minimal. CP angle endoscopy is different than intraventricular endoscopy or transsphenoidal endoscopy. The stakes are very high, and there's no port access or conduit like the nose or the endoscope trocars, for example. There are critical structures in the area, and one needs to be very conscious about the movements of the endoscope. It's not just the in and out movement of the endoscope, it's also whether you're tilting it to the side or whether you are rotating the endoscope in order to look around the corner. So we have to be very careful about the lever effect, especially when we're trying to introduce the endoscope deeper to the nerves. When introducing the instruments, again, depending on which area we're operating on, it's quite important to be able to see the tip of the instrument, and we'll see a video later on about that. Similarly with high-angled scopes. And whilst doing all these tasks, it's very important to keep, to stay very conscious with the eye-hand coordination. So whenever you're introducing an instrument, it's an extra task in CP angle endoscopy that needs to be monitored. And I will try to depict that with this video, just to show you that there is, just to show you that there is a difference when working superficial or deep to the nerves. When you're working superficial to the nerves, then it probably doesn't matter. You can keep your endoscope fixed and you can insert your instruments parallel to the endoscope. But when you're trying to work deeper to the nerves, then you have to withdraw the endoscope. It's a type of accelerate or clutch movement where you withdraw the endoscope until you see the tip of your instrument, and then you can safely navigate deeper. So you withdraw the endoscope until you see the tip of the instrument, and then you go deeper. That's when working deeper to the nerves. Endoscopy has some inherent advantages and disadvantages. The etymology of the word, meaning that you have your view, your image source from inside the operative side, has the great advantage of the panoramic view, looking around the corner, or a very good close-up quality without necessarily having to zoom in or zoom out. The disadvantage is that the image source is very close to where you're operating, so bleeding can be annoying, clearing the lens can be annoying, and sometimes, especially at the initial stages of the learning curve, it can be very, very difficult to get used to. Indications, it's still, in my opinion, a gray area. There are good indications, there are indications that are still questionable. You can find all sorts of indications in published series and literature. I personally haven't used it for all of these indications. I think some of them are a bit far-fetched. I think it's good for cystic lesions. I think it's good for tumor in the IAC, which I'm sure that Professor Schroeder will show us later on. Same with MVDs. I think they're a very good indication, and we'll see that in Professor Schroeder's talk as well. Epidermoids are probably one of my favorite indications in CP angle endoscopy. I think they're very useful. Cystic vestibular schwannomas, there's a discussion about that, and we'll look a little bit into the evidence and into techniques, but I think you have to have very specific surgical goals. Meningiomas, they're not a fantastic indication. When you want to achieve something specifically, you can use endoscope assistance, but in my opinion, they're not a great indication. And then combined approaches, I think endoscope assistant in combined approaches, especially where lateral approaches meet anterior approaches, can be very useful. And I think that Professor Fröhlich might talk a little bit about that later on. Cystic lesions, you can get excellent views. You see the lower cranial nerves, you see the 7 and 8 complex, the trigeminal nerve in the depth. When you have a cystic lesion, endoscopy is a very good option. And you see there what I was saying about considering using a retractor, which just makes life easier in terms of not having to retract cerebellum with the endoscope itself and the patty. Again, cystic lesions, good indications. I'm going to skip through a lot of videos because I know some of them will be covered by my colleagues later on. All I want to show is this is a normal bipolar. This is a bayoneted bipolar, and the goal here is just to fenestrate, so it's actually a fairly easy task. Skipping through the videos, this is the facial nerve stimulator that can be used as a dissecting tool. It's very shaky and it's in fast forward. If the surgical goal is to fenestrate, in my opinion, it's useful to do as many or wide fenestrations as possible, because otherwise the cystic lesions tend to accumulate. But as I said, the indications depend sometimes on what we're trying to achieve. This is a young patient with a meningioma. In my opinion, this was not a great indication, and I'll explain why. It's a young patient who had a large posterior fossa meningioma treated microscopically with a suboccipital lateral approach. This was exiting through the jugular foramen into the neck, and you can see that the lower cranial nerves are on the tumor, which is limiting or was limiting my resection. I did try to work in between the nerves, I couldn't. So I thought I'd use an endoscope to try and see what's happening behind the cranial nerves and how much tumor there is there. And yes, you can see the tumor residual there. And by using some angled instruments, you can probably, let me skip forward to the angled instruments, you can probably even resect a little bit of tumor. But does this really make a difference in this case? I don't think in this case endoscopy was a particularly good choice, or it changed the outcome. On the contrary, this is a case where endoscopy was not used. This is a meningioma going into the porus, and you see the preoperative and the postoperative scan. The patient did very well, but she has a small residual in the porus. So this porus was not drilled, and no angled endoscope was used. So whether the outcome would have been different or it would have made a difference, that's up for discussion, but endoscopy was not used in this case, and it could have been. A few words on troubleshooting, and I'll try to show you a video about that as well. It's a visual medium, so it depends a lot on the image quality. And we often tend to show very good videos, very clear videos, but we all know that the image quality is sometimes not perfect. And I think for people who want to start doing this, they need to have a mental checklist. Like with any form of endoscopy, you need to pretty much check everything when the image is not of a high quality. That means the light source, the cables, the optics, the lens, but also the orientation of angled scopes, whether you're wasting the light in a direction that is not absolutely necessary. Similarly, endoscopy can work in an air or in a fluid ambience, but when you're working between the two, then it can become very unclear and very annoying. I'll show you a video where I'm trying to depict that. This is a small, well, a moderate, let's say, petrous meningioma that is treated microscopically, and then trying to identify the nerves behind the meningioma. This is not absolutely necessary. It's more useful in schwannomas. And you can, sorry, I'm trying to skip through the video, but you can probably see the lower cranial nerves at some stage at 6 o'clock. But the 7 and 8 complex is very difficult. You can see them at 6 o'clock, and they're very easy to identify because they're not blocked by the tumor. But the question is, where is the 7 and 8? And the arrow is on the 7 and 8 complex behind the tumor, but you see that it's very dark. And you can see what you want to see. If you know where an anatomical structure is, you can probably see it better. And now you can just about see the 7 and 8 complex behind the tumor. It's probably not a particularly useful indication in a meningioma, and it usually fails, in my experience, in the large vestibular schwannomas where it actually matters. What I'm trying to show here is that the image quality is very dark. And probably after checking everything, one of the reasons may be that it's an angled scope and it's not rotated enough, and a lot of the light is reflecting on the petrous bone. All I'm trying to say is that there is a checklist, and you have to check everything when you don't get the image quality that you want. This is an elderly patient who was operated many years ago for a vestibular schwannoma, had a recurrence, unfortunately was lost to follow-up. Was elderly, unwell, had a pacemaker which was not MRI compatible. So we were thinking whether to do anything and how we're going to tackle the problems of the duration of surgery, the positioning in a patient who's very unwell. And we decided that our surgical goal would be to just drain, fenestrate, and debulk this tumor rather than go for a good resection. So we put him supine with head rotation, and you can see some endoscopic view. So this was addressed fully endoscopically. And the reason it was addressed fully endoscopically was that we had very limited expectations over resection, of the degree of resection we wanted to achieve. And you can see the pitcher's bone, the brainstem, tumor capsule, and the nerves behind it. And I'm going to skip through the videos just to show a little bit of technique, because I know that Professor Schroeder will talk more extensively on vestibular schwannomas. So you see it's a hollow tumor now after using the Cusa, and you see the fenestrations and the brainstem behind it. And we know we're leaving tumor behind in this patient, but the surgical goal was to just debulk a patient who is very, very unwell with a 1-hour operation and with a very, very small, minimally invasive access. And he actually, in retrospect, did very well, but it's up for discussion whether these are good indications or not. If you take a look into the literature, there are published series on vestibular schwannomas and fully endoscopic resection, and this just depicts very nicely the setup. And they often show good results in terms of length of stay, in terms of gross total resection. However, this needs to be interpreted a little bit with caution, because look, for example, at the tumor size. These are very, very small tumors that would have done equally very well microscopically, or in some parts of the world, like in the UK, for example, quite often these tumors are watched on watchful wait, or they go for gamma knife or stereotactic radiosurgery. So I think in terms of the indications, we can discuss about them, and it would probably be more useful to listen to Professor Schroeder's talk on vestibular schwannomas and the other indications. Again, this was a very specific indication. This was a patient post-gamma knife who developed a facial nerve weakness with cupping cysts, which we sometimes see in vestibular schwannomas, post-gamma knife. And you see a very, very small approach, just because the surgical target was to fenestrate the cupping cyst. And you see the cupping cyst there. And this is very, very straightforward to fenestrate. Again, I'm going to skip through the videos, I'm sorry. So this is a normal bipolar, just fenestrating the cyst, and that's the superior pole, north pole, and the same in the south pole, and some of the tumor debulk or biopsy. I think it depends. We have to have very clear surgical goals on what we're trying to achieve, and we'll listen about this a little bit later. Limitations and technical problems in endoscopy in the CP angle. It's a visual medium, so if the lens is not clear, then we're not going to be able to have a good image quality. However, these clear lens systems that we use in transsphenoidal surgery, in my opinion, are too bulky to be used in the CP angle and probably too dangerous. When using a freehand technique, we withdraw the endoscope all the time, so it's easier to clean. When using a holder, I think the right position of the holder and the use of irrigation can be particularly helpful. There is a bit of a trade-off between having the endoscope fixed with the holder or having and being able to work bimanually versus freehand or versus an assistant. It tends to be very shaky in the freehand option. Then again, it gives a very nice 3D perception. So when it's the surgeon who is using a freehand technique, it's very nice, even though it's shaky. When it's an assistant using the freehand technique and the surgeon working bimanually, then it may be a problem because the shaking is very, very difficult to process. We've discussed a little bit about holder problems. And then there are patient factors and tumor factors. When there are vascular tumors, then endoscopy is probably not a great idea. The consistency of the tumors is important. A cystic tumor is probably a better indication than a solid tumor for endoscopy. And then patient factors like the elderly unwell patient I showed earlier, and the surgical goal, what degree of resection am I trying to achieve? I'm going to skip through the MVD videos because Professor Schroeder will cover that later on. This is a combination of microscopic and endoscopic technique. It's a patient with a CPP who had a lateral suboccipital approach, and that's at the end. Sorry, that's at the during the microscopic resection. You see some lower cranial nerves there. I'm going to skip again. And then with the endoscopic technique, you see towards the end of the resection, you see a very clear view of the nerves into the jugular foramen and into the porus. And then by rotating the 30 or angle degree endoscope, we can see that there is still tumor left on the medial side, which we're expecting with these tumors. Apologies. Again, epidermoids are going to be covered later on by Professor Schroeder. I just want to show you the angle of approach with the microscope and with the endoscope. So again, endoscope assisted technique. So the tumor here, an epidermoid, was resected with a posterolateral approach microscopically. And towards the end of the resection, you see where that patty is. Keep an eye on that patty. No matter how much we flip the scope, there is a limitation to the line of sight. But later on, if we insert an endoscope, you see where the patty is, and we see that there's still a lot of tumor left anterior to the brainstem. So angled endoscopes can really offer this view around the corner behind structures to see about hidden tumors. Safety and pitfalls, so these are basic concepts that need to be known before starting CP angle endoscopy. We've talked about the drift in some of the endoscope holders, although nowadays there are really good holders in the market. We've talked about the coordination between surgeons and the constant shaking when using freehand technique. I think this is probably one of the most important take-home messages, that it's a different technique when working deep to the nerves or superficial to the nerves. So when the nerves are superficial to the lesion, between the surgeon and the lesion, then we need to take care to retrieve the endoscope so that the instruments are inserted safely under direct vision. When the nerves are deep to the lesion or where we're working superficially, then it's very safe to just insert them in parallel. It's important to know the equipment and its limitations. And another consideration is procedural length, especially at the beginning of the learning curve. It might prolong the procedure, especially if the equipment is not planned. And when I started, there was a lot of nagging in theaters about doing a microscopic case and then having to bring an endoscope stock in the end. But over the years, people get used to it. The endoscope stock stays in theaters, and it's very easy and very straightforward to say, I want to use the endoscope now and take a look around the corner. I think we've covered most of these things about freehand and holders and the 3D perception. There is a trick on resting the endoscope on the petrous bone, but it depends on the surgical target, and the same with the cerebellar patty. One needs to be a bit cautious with prolonged high light intensity, even though it's a cold source. If you're working for several hours with light on structures without irrigation, then it can potentially cause problems. The use of a retractor, especially at the start of an operation, can potentially be helpful, but there is always a constant debate on whether using retractors or not. And we've talked about the air or CSF ambience. Again, I'm going to skip through this video very, very quickly because my colleague Professor Schroeder will cover the epidermoids later on. All I want to show in this video is the use of a malleable suction. This is going to be, this is an epidermoid in a young patient treated with microscopic technique, and then at some stage realizing, okay, there's a lot of tumor behind the nerves. We can't dissect this with the microscope. You see, this is the trigeminal nerve. It's a heavily distorted trigeminal nerve going into Meckel's cave, and at 6 o'clock, it's 7-8 complex. And I'm just going to skip through the video to show you, you see the malleable suction. So this is a suction that can be bent to the angle that we feel is necessary or useful for this particular operation. And again, this is freehand technique, but the angled instruments and the malleable suctions, I think this is the suction into the Meckel's cave. I think it can be very, very useful. And then let's say towards the end, you can take a look into Microvascular or behind the nerves. I don't want to show you the whole video because then there will be an overlap and duplication. In terms of learning curve, CP angle endoscopy is not easy. In my opinion, CP angle endoscopy should be at a late stage in a staged approach to training. It's at the top of the learning pyramid. I would start with simple pituitaries. I would start with transsphenoidal surgery, with interventricular surgery. They have their tips and tricks and their problems, but I think the CP angle is a high stakes area that I would live for last in the learning curve. Bleeding can be stressful in any endoscopic application, let alone the CP angle. There tends to be an over-enthusiasm when a new technique is introduced, and then after that there is a period of disappointment and disillusionment, and hopefully we can reach a sort of balanced, measured approach later on towards the end of the learning curve. And if we can spare younger colleagues this steep variance and get them straight to the balanced, measured approach of utilizing a tool, what can be done, what should be done, I think that would be very helpful. In terms of further publications and reading, if anyone is interested, this is a very good article on an anatomical study. It has excellent graphic illustrations that show the trajectory and the view of the endoscope depending on where the surgical target is. But most importantly, they have a flow chart that can be useful in decision making on the endoscopic approach and routes in the posterior fossa. In my opinion, in the majority of the cases, endoscope assistance is the most important aspect of CP angle endoscopy, but it's perfectly feasible and technically safe in very highly selected cases to do fully endoscopic techniques. And I think we'll see from the next speakers some of these indications. It all depends on the surgical goals. What am I trying to achieve? When can I stop? What do I have any alternative options? The key is in trying to improve visualization and selecting the patients in order to have a safe technique. And I think at the end of the day, it's useful to have tools in our armamentarium and use them as necessary and when needed, rather than be slaves to a specific technique. I think it's very useful. And I think it's very useful when it's combined with other techniques. What can we expect from the future? Three-dimensional endoscopes are already there. In my experience, they haven't really changed very much in what we do in CP angle endoscopy, but I would be very keen to hear what the other speakers think about this. The advent of exoscopes, I think they work well together as a combination, but exoscopes, even the etymology of the word says that it's a different technique. So the exoscopes will not replace the endoscopic techniques. They can't replace them because the source of the image is outside the operative site. So I think it's useful to combine these things, but they're not going to replace the endoscopy bits. I think what we can expect from the future, and that's some work from my colleague Kaspar, who is one of the engineering professors at QMUL, is soft robotics, which I think once we have these applications in endoscopy and we are able to safely navigate through them, it would be a breakthrough in what we do. And if the future can at some stage be rodless, that would be the next breakthrough. That's all from my side, and I'm looking forward to Professor Schroeder's and Professor Fröhlich's talks.
Thank you so much, Dimitris, for this very, very interesting talk and the discussion about the advantages, disadvantages, limitations, key issues. Now I will give the floor to Professor Henri Schroeder, who will discuss with us several pathologies that he managed with endoscopic procedure. Please, Henri.
Yeah, thank you for the invitation to this webinar. It's a great pleasure to be here with you and to discuss about endoscope-assisted skull-base surgery. I want to show you just some examples where I found the endoscope very useful. Dimitris gave a nice overview about the concept of endoscope assistance. That means it is the combination of using the microscope and the endoscope in skull-based procedures. And for me, in this area, I always do it endoscope assisted. I don't make it pure endoscopically. I did some cases, but I really did not saw an advantage. This is completely different to endonasal surgery, where you have this long, deep surgical corridor where we use a purely endoscopic technique. And as Dimitris mentioned, microsurgery and endoscopy is just a technique every new surgeon should be aware of and should be mastered. It's not a discussion about endoscopists and microsurgeons. That is really not really true. So what we have to keep in mind, there are some pitfalls in endoscopic surgery, and this is a visual field. When you work with a microscope, you always see all structures which are in front of you. Even if you go deep down in a surgical field, you see the structures. They are not in focus, but you recognize if you touch them with the shaft of your instruments. If you have an endoscope, as long as you stay with your lens in front of these structures, it's the same. But if you go deep down, for example, in between 7th and the 5th nerve, you go deep down in the field and you dissect here, you don't see what your shaft of the instrument is doing with these structures. And that is really dangerous. And I had the facial palsy in one patient because I did not recognize it. I only heard it during the monitoring that I touched a nerve. And that is very important. If you go deep down in the structures and you pass important neurovascular structures with the tip of the scope, you must be very careful that you do not damage these structures which are not in the view of the endoscope. This is an example. You see the video. I go deep down. I see a small remnant of an epidermoid on the contralateral side of the clivus. When I try to dissect it with a microscope, it's very difficult because I don't see very well, but I see if I touch these structures. When I use the endoscope now, I have a perfect view in the depths, but I have no control of my instruments to the superficial structures, and that you should keep in mind. Another thing, what is also mentioned by Dimitris, is the endoscope tip can really become very, very, very hot. It's called a cold light fountain, but it's not cold light, it becomes very hot. And if you place the endoscope in front of a cranial nerve and leave it there without irrigation for a longer time, you may get a thermal damage to the nerve. Is pure endoscopic surgery better? There are some reports, Dimitri already mentioned this, but I think it makes no sense. If I have a structure like here, this epidermoid, and I have to dissect the perforator from the structure, I have a perfect view with a microscope. I have a 3-dimensional view. I have a perfect optical resolution because the lens has a large diameter. Why should I use this endoscope? Why should I use an endoscope for this step of the surgery? In my opinion, that really makes no sense. So it's a combination of microscope and endoscope, at least in my hands, is really preferable. It's different if I have this situation. There is an epidermoid growing into the internal auditory canal and the nerve is in front. With a microscope, I cannot see well. Now I switch to an endoscope. It's a 30-degree endoscope. I may look directly into the canal and I can dissect this part of the tumor without touching the nerve. And that is a big advantage of the endoscope. If I don't see well with a microscope, because I have to look around the corner or it's in the depths, then the endoscope makes sense, in my opinion. And also some people say endoscopic surgery is less invasive than microsurgery, but it's also not always true. I have seen a Chinese surgeon showing very nice surgery in the pineal region, very good image, very good quality. But then he showed to us the approach he made. It was a 5-centimeter hole where he had enough space to navigate around the endoscope. If you make a keyhole of 1.5 centimeters or 2 centimeters, the endoscope may also restrict your movement. So this is a pineal cyst. You see that here, and you see there are some veins here. When we make our approach, it is about 2 centimeters in size. I see these veins, and if I bring the endoscope in and work in the depths, for sure I will damage these veins, but I don't want to do that. That's why in this case, I think the microsurgical technique is even the better option, because if I go in and out with my instruments, I see what I do to these veins. So first I dissect the veins to get some space, and then I work in between the veins. So I did not coagulate these veins. When I use an endoscope, I see perfectly well to the pineal region, but with my instruments, I probably will damage these veins, and these are very large, so I don't want to damage these veins. So that's why, again, the microsurgical approach sometimes is less invasive than the endoscopic approach, because the endoscope needs some space. You see, I work in the depths, and here is a vein, and here's the other vein. If I have my endoscope here, for sure, with the forceps, I will damage these veins. So this should be considered. I hope we can discuss later on. The surgical technique is already mentioned. We start with a microscope, then I use the endoscope freehand. I always insert the endoscope freehand, so I don't look to the microscope while introducing it. I look to the view of my endoscope. And then when I want to have a tumor dissection, I fix the endoscope. And in my setting, the endoscope holder is on my side, and I have the small a mechanical one. I don't use the pneumatic, which is very bulky, and Dimitris is right, and it should come from the other side. But I think it's very important that we have both hands free. I want to have a microsurgical bimanual dissection. So a good example is a vestibular schwannoma. If we have these small schwannomas, we always use the supine position. We just turn the head to the contralateral side, and we turn then the whole table, that I have a good view into the CP angle, and the cerebellar surface is going down by gravity, so I don't need a retractor. This is our incision. We have it curved because I want to look to the fundus. If I have trigeminal neuralgia, I make a straight incision, hemifacial spasm as well, but if I want to look to the fundus, I have a curved incision because I need this view to the lateral side. Always we do monitoring of acoustic evoked potentials in facial EMG, and we use a middle retrosigmoid craniotomy. And it's very important that you expose the margin of the sigmoid sinus and see the angle here to the transverse sinus. So I want to see the knee and here, and then we make this opening here. I want to be as close to the sigmoid sinus as possible to avoid retraction. We use a spatula, a suction spatula, that is not used for retracting the cerebellar surface, but this is just to keep the field clean. There is a suction connected to the suction spatula. I place it at the lowest point in the craniotomy, and then I can dissect with both hands free. So I don't need a sucker, it's just a third hand. So I take one forceps to keep the tumor, and I take the other forceps to dissect the nerve in perpendicular axis to the course of the nerve to avoid stretching of the nerve. And I can dissect all the time. The assistant is irrigating, and I keep a very nice clean field, even if there is some bleeding. I found it very helpful. So just an example, this was a 20-year-old male, and he had a hearing loss on the right ear. And then MRI showed he has a tumor on the left. So the left ear is his only hearing ear. Then he went for consultation, and most of the people recommended gamma knife treatment. You see the hearing on the left side is good, right side is very bad. But if you look to the literature, in the long term, we have a very good tumor control after radiation therapy, but the hearing preservation rate was just 1/3 of the patient after 15 years. So that's why I think even in young patients with small tumors, I usually prefer surgery. The problem is the tumor is located in the fundus. We want to preserve hearing, so we cannot drill too much of the posterior wall of the internal aortic canal. We should not open the posterior semicircular canal or the vestibule, because usually you lose then your hearing. And there is still an angle when I look from here to the fundus, which is not visible under the microscope. And that is a time where I use the endoscope. You see, this is a 7 1/8 nerve. This is the posterior wall of the internal aortic canal. So I start my dissection with a microscope, because the middle part of the tumor I can see very nicely with a microscope. So I think it's no need to start from the beginning with an endoscope, because you have a better visualization in straight lines, three-dimensional view. But now you see it's a blind dissection. And then I switch to the endoscope. I fix it to my mechanical holding arm. And then I can use both hands for dissection. And with an angulated instrument, I can follow the plane from the vestibular nerves, the residual fibers of the vestibular nerve, and I can dissect under direct visualization the tumor out of the fundus. Of course, we have an eye on the acoustic evoked potentials, and we said if they will decrease, we have to immediately stop the surgery to preserve his hearing. But we were lucky, there was no problem with acoustic evoked potentials, and we could get a gross total resection. And now I use the 45-degree endoscope. We look to the fundus. You see the transverse crest, and here's the area where the tumor was. And this is the amount of drilling what we had. And this was the angle where we looked in with the endoscope, and we could preserve a good hearing in this boy. It's now 5 years after surgery. In the large tumors, initially we had also the supine position, but the problem is that all blood and CSF is accumulating in the surgical field. And then I have to use a suction, and I have to dissect with one hand, what I don't like. I want to have two forceps in my hand. That's why we skipped also to the semi-sitting position. It's very important that we have the control of air embolism with an endoesophageal echo, which is very sensitive to air bubbles. And then we make the approach. The disadvantage is that we have always some kind of cerebellar retraction. That is true. And we have the risk of pneumocephalus, especially in older people. And we have the problem of air embolism. It's not so inconvenient because we have a handrest here. And if you have long enough arms, it's not a problem. So there was an 11-year-old girl which came at Christmas time last year, and she had just headache and walking problems. You see, she has still a good hearing. And we make a semi-sitting position and start with opening of the internal aortic canal. Again, here we start, of course, with a microscope. We make a 180-degree unroofing of the optic canal. This is a facial nerve stimulator. We are looking for an atypical course of the facial nerves. Then we open the capsule with bipolar, and we take specimens for histology. And then we have a vigorous debulking of the tumor with the ultrasonic aspirator. And now you see again the advantage. The tumor is bleeding, but under continuous irrigation, because of the semi-sitting position, I can dissect with both hands, and I have always a good plane. Identification of the facial nerve in the internal aortic canal. This is a stimulator, confirming this is a facial, that is the vestibular nerve. So again, by manual dissection, and always the assistant has to irrigate. This is a cochlear nerve, which has a nice plane for dissection. So usually I try to dissect in a perpendicular axis to the course of the tumor. Then we come to the brainstem here, and we identified the facial nerve. Always irrigation all the time to have a good view, another debulking of the tumor, and stepwise the tumor is dissected. And you see here also there's a nice arachnoid plane around the tumor, and with two forceps we can nicely dissect. I don't have to care about hemostasis because the blood is washed away with irrigation. And here the facial nerve is coming. You have to be very careful because in the zone between the cisternal segment and the meatal segment, the nerve is usually very sticky, but here we are lucky we could dissect, and we had no bad trains in the monitoring, so we could have a gross total resection of the tumor, although there was a long contact between the tumor and the facial nerve because of the size of the tumor. So all that is done under a microscope. I think it makes no sense to use an endoscope for these steps of the surgery. Finally, the tumor is removed. Facial nerve function is confirmed. And then we use the endoscope to look for open air cells. It's very helpful because with a microscope, it's hard to see them. And here we also found a small residual tumor in the fundus. And these are the two main tasks of the endoscope in vestibular schwannoma surgery, to look to the fundus and to see whether there are open air cells. And she made a quite good recovery. This was a lady with a neurofibromatosis type 2. She was deaf on the left ear and she developed a facial palsy on the left side. She had radiation before. Supine position, 7 and 8, and this was a facial nerve. So we confirmed stimulation. There was a very weak response, not much, very weak. So we again open the internal auditory canal. We have the microscope again, resect the tumor. Initially, I tried to preserve the facial nerve. I thought maybe it's just compressed, but here you see the nerve is really heavily involved in the tumor. There was no chance to preserve the facial nerve. And then under irrigation, here was a plane, but the nerve finally was gone. There was no chance. So we removed very aggressively the tumor from the porus. And my otologist, he exposed the facial nerve in the mastoid area. Here we cut the facial nerve. This is a facial nerve. And then we make a connection between the internal auditory canal and the mastoid. And this is under an endoscopic view because the angle of view was very bad. So the endoscope was very helpful to drill this area. Then we took a sural nerve graft, 6 centimeters long. And we placed it. This is the mastoid area of the facial nerve. We cut it and we placed the nerve here to the central stump. And then the endoscope was extremely helpful to see whether the nerve is really in plane, fascicle to fascicle. This was hard to see with the microscope, but with the endoscope, with the 30-degree, I could see it very nicely. And then we don't make a suture, we just took glue because the nerve has no epineurium in this area. This is the approach. 3 months later, 1 year later, show just a fat graft, and she has really a good function. You see there's a good function. The forehead is a little bit weak, but it worked very well. So now another very good indication is epidermoid tumors. This was a lady, she came with a recurrent tumor. She had already 2 times surgery, but this part of the tumor could not be resected because they used just the microscope. And when you use the microscope in this direction, you cannot see down here to the cerebellopontine. That was a problem. So we make a superior retrosigmoid approach. We just go in between the cerebellar surface and the tent. And my initial question was, where is the trochlear nerve? I could not see where's the trochlear nerve. And with the endoscope, I could identify it. Initially, I thought the trochlear nerve is pushed upwards, but now I see with the endoscope that the nerve is running from the tent and going down. So the tumor pushed it down. So with this knowledge, I could resect very aggressively in the area of the tentorial edge because I know the tumor is down. It was a very helpful information before the surgery. So this is all done again under the microscope, resecting of the tumor under the CPN, under the tent. And I was very lucky. This is a trochlear nerve in the posterior part. Although it was a recurrent case, there was a good plane. It was quite sticky, but there was always a plane, and with bimanual technique, I could dissect all the tumor capsule from the brainstem, which is sometimes not possible. And it's really ill-advised. If it's very sticky to the brain surface, you should not force a complete resection, only if you can preserve the pia mater. And now you see I use a 45-degree endoscope and a curved instrument, curved suction, to go down here to the tumor, which is indentating the cerebellopeduncle. This was only possible with endoscopic visualization. You have no chance to get this tumor out simply with a microscope because it really goes far down. But with this curved instrumentation, I could get a very good resection of this tumor. And here you see the indentation is completely gone and she is doing fine. This was a lady presenting with facial numbness. and she had a lesion really dilating the Meckel's cave enormously. So this was a slow growing lesion, and there was also compression of the brainstem. When we discuss this case in our courses, most people say, yes, we make a Kawasaki approach or a combined approach, but I think the most easiest way is just to make a retrosigmoid approach, take the tumor which is compressing the brainstem, and then we use an endoscope to look to Meckel's cave. And that was done in this case. You see the petrous surface, this is tentorious surface. There is some hair inside, so a typical dermoid. Tumors are vascular, very nice to dissect. This is all done under the microscope again. You see here 7/8 nerve, dissecting the plane in the bimanual technique. And then identification of the trochlear nerve, which runs under the tent. And this is a trigeminal nerve. And here the tumor was very sticky, especially when it goes into Meckel's cave. So I make no attempt to take the capsule away from the nerve because this will destroy the stretched fibers. And here you see is a blind curettage under the microscope. And that's why this is a time to switch to an endoscope. It's again a 45-degree endoscope, and you look nicely into Meckel's cave, and with curettes and curved suction, we were able to evacuate this tumor very nicely. And as I said, I did not make any attempt to remove the capsule from the nerve fibers because this will destroy the fibers. And post-op shows the complete evacuation of the lesion and the facial numbness improved. This was an interesting lady. She had a progressive gait and balance problem, 65-year-old. And she has a lesion. It's a foramen magnum. And you see the tumor is more prominent to the left side than to the right side. So a far lateral approach from the right side was chosen. Tumor is exposed. And then ultrasonic aspiration is used to debulk the tumor and dissect it. It was a good arachnoid plane. The problem is I could not see really in front the anterior part of the foramen. This was not possible because of this opening. And then I switched to a 30-degree endoscope again. I fix it, and I have a bimanual dissection of the tumor, the ventral tumor part, which is available. So I could avoid a lot of drilling of the condyle. It was not necessary because with an endoscope, I can take this tumor, which is more ventrally located. You see bipolar coagulation of the tumor matrix, and the inner layer of the dura was resected. The periosteal layer remained in place. So the endoscope gives you a nice view to this area and makes sure you have a gross total resection. This is the ventral surface of the brain's medulla. This is the amount of drilling. You see, I just go to the posterior part of the condyle. I don't take the condyle. And the blind corner, I can look with an endoscope. This was a lady with, oh no, my time was over. Huh? I skipped, this was a cavernoma, which resected, and we looked the endoscope just for inspection. I want to show you better the case of this lady. It's also interesting. She had an unsteady gait and balance problems, and she had a pica aneurysm pointing to the brainstem and makes an edema here. Very, very strange symptoms of an aneurysm. And the interventionalist said, no, we cannot coil it because there's an acute angle. If you put coils here, we have an occlusion of pica. That's why she came to us. And we said, okay, we do it. We made an inferior retrosigmoid approach. But you see, there's not much space to look to the aneurysm. That's why I used a 45-degree endoscope to get an idea about the anatomy. And you see here, this is a vertebral artery. This is pica origin, and this is the aneurysm. I wanted to see where are the perforators. And you see here behind the aneurysm, there are perforators running. Then I tried to clip the aneurysm under endoscopic control, but if the endoscope was in place, there was no space for the clip applier. So I had to go back to the microscope. I dissect the neck, which was sticky to the brain stem. And then I clipped the aneurysm under microscopic view, but I could not see very well where the clip is going. But with my knowledge in mind from the endoscopic inspection, I just put it parallel in this course, but you see, I cannot see the tip of the aneurysm clip. So I'm not sure, is the perforator involved or not? And then again, the endoscope was extremely helpful to give you a view to the clip position. So we go in, we see, aneurysm is completely clipped and the perforator is not in the clip tip. So everything is good. That gives you a safety. So for aneurysm clipping in the posterior circulation, I think the endoscope is very, very helpful. Microvascular decompression is also a very good indication. Trigeminal neuralgia is helpful, not so much like in hemifacial spasm, because usually you can look in straight line to the root of the trigeminal nerve. The incision is straight, exactly in the knee of the sinuses. And then we have, simply by gravity, the cerebellum falls down, and we have a good overview. This is a tent, this is a petrous bone. Sometimes you have a very prominent suprameatal tubercle, and then the endoscope is very helpful. So in this case, you might think SCA is compressing the trigeminal nerve. We have this suprameatal tubercle, which avoids the view to the Meckel's cave. But if you use a 45-degree endoscope, you see there is a vein. The vein is a problem. And this we had in several cases. You see there is with a microscopic view, I could not see the trigeminal nerve, but with the endoscope, I can see it. There is a vein really indenting the brain. So I looked, is there a collateral for this vein? And then on an endoscopic visualization, we can coagulate the vein. And then we can take a scissors and cut. You see, it's really an indentation. So the compression in trigeminal neuralgia is not always at the brainstem. We have several cases where the compression is distally, and these patients improve very much. A better indication for using the endoscope is hemifacial spasm. In this case, we make an inferior retrosigmoid approach. Same positioning, monitoring, and the lateral spread. Lateral spreads were recorded. And usually, if you have a good decompression, the spread is gone. This is a red line here. And it's a very small approach. And again, I tried some of these approaches purely endoscopically, but I don't find it very useful. Sometimes we have only 4 millimeters here. And when the endoscope is in, it is hindering my dissection because I always touch the endoscope. So I use a microsurgical technique to open it. And then if I open the cistern, have released the lower cranial nerve group, then we use the endoscope. And you see how much better you can see. You see the basilar. This is a common trunk giving rise to Ica and Pica. And you see the facial nerve is here and there's the compression down here. It gives you the view down to a pontomedullary sulcus, and this you cannot achieve with a microscope. Facial nerve, intermedius nerve, eighth nerve. Then we put on a microscopic view usually the Teflon inside, and then we check again with the endoscope. The Teflon should always in a place not exactly where the compression was. So we always try to avoid contact between facial nerve and the Teflon as much as we can. We had some cases where we had to use a purely endoscopic technique to decompress. And you see here, this was a patient with a Pica loop going far up into the brainstem. And with a microscope, I really could not see it. I tried to get there, I had to retract, then the acoustic evoked potentials went down, and you see, with a microscope, no chance. And then we use a 30-degree endoscope, a 45-degree endoscope, and you see the Pica is running here. This is a branch of the hypoglossal nerve showing the origin of Pica, and you see the Pica goes into the brainstem here. And because I couldn't see it with a microscope, I used an holder to keep the endoscope fixed, and then with a dissector, I could mobilize the vessel out of the brainstem for decompression. So that was very helpful. If the compression is deep down in the pontomedullary sulcus, then I think it's really a nice to make it with an endoscope. This was a patient with a typical hemifacial spasm for 20 years. And this was interesting because there was no vascular conflict, but there was a strangulation by arachnoid. You see this just like in hourglass. It was really a strangulation. This is a facial nerve coming here. It goes down to the pontomedullary sulcus, and here it looks like it's really a strangulation. So there must be a this ontogenetic thing, I don't know what it is. So we could stimulate the facial nerve here, was working, and then I just opened the arachnoid, and we also opened the perineurium with the diamond knife, and then it completely resolved. We had 2 of these cases where the arachnoid was really strangulating the nerve at the origin here at the brainstem. Very interesting. And it went completely away also. So I think I can conclude that the endoscope-assisted microsurgery for lesions in a CP angle is a very, very helpful tool. And I want to encourage all the young people to try it, because it makes the life easier. It enables a view under corners at the skull base. You can look around the jugular tubercle, the suprameatal tubercle. You can look into Meckel's cave. You can look into the fundus of the internal auditory canal. So thank you for your attention.
Thank you so much, Professor Schroeder, for this very impressive talk and impressive video. I think we are now all convinced of the interest of combining endoscopic and microscopic approaches. It's not a fight between the technologies, it's just a way to improve the visualization, and the combination of both is truly relevant for accessing some areas which are hidden with the microscope. So now we will move to Paris, and we have the chance to listen to Sebastian Fröhlich now. Please, Sebastian, you have the floor.
Thank you very much, Michael. Sorry, guys, Dimitris, Henry, nice to see you. I was a little bit late, but I was just late 5 minutes. So, subject of my talk is, as a previous talk, endoscopic assisted CPA surgery, indication for using the endoscope when you work in the area of the CP angle. Let me just share my screen. Yes. Do you see it? Yes. Can you see it?
Yes, we can see it.
Okay. So I have to say that I am using quite often the endoscope in skull-base surgery in my practice. In fact, the endoscope is used in almost every cases. At least it's ready to be used in almost all of my cases. This is what skull-base surgery was around 20-25 years ago. We were learning skull-base surgery, learning approach, open approach, just with the microscope. But definitely now the endoscope came, and the endoscope is everywhere. We have used the endoscope through the nose. We have used the endoscope through small craniotomy, using the keyhole concept and the endoscope in addition to this concept. And we are now, I have to say, using it in any type of open approach. And quite often the endoscope can reduce the invasiveness, the extensiveness of an open approach, because it gives you additional exposure without increasing, for example, the craniotomy or the drilling of the skull base. So my setting for endoscopic assisted surgery, first, the endoscope is always ready to be used. And I think it's extremely important for anyone who wants to take advantage of the endoscope, not only using it, but really take advantage of the endoscope, is to have it ready and to use it even when it's not useful. To check the tumor cavity at the end, to check the CP angle once you have resected a schwannoma, once you have done an MVD, and progressively you will find some indication where, in fact, you can work, you can do something with the endoscope. But at the beginning, if you want to reach the point where you will work with the endoscope, you first have to use it many, many times just to check. Cranial nerve monitoring is very important. There was the previous speakers said several times that you don't see on the side of your endoscope, so you can push a little bit cranial nerve on the way and the monitoring is in fact your eye on the side or your eyes behind. Neuronavigation is very important also for those cases. Endoscopy is a type of navigation, but it's sometimes a complex anatomy to look at from a very unusual perspective, and having the neuronavigation to help you is not a bad idea. I am not using holder. I will show you some videos. Personally, I don't like holder a lot, but I always prepare, or I have an endoscope holder ready. We just got the pneumatic holder. I like it. It's nice if you need it, but again, I'm not using it very often. I use different types of endoscope, 30 degrees, but not only 45 degrees, 70 degrees. And to work with those ungulated endoscope, what I think is absolutely mandatory, and Dimitris showed an example of it, it's a malleable rotative suction. That's, in my opinion, key for endoscopy in general. So I am using, in fact, for transcranial endoscopic assisted surgery, the same technique I am using through the nose. We publish it, and we called it Chopsticks Technique. In fact, what it means is that I am holding the endoscope with my left hand, and I have this rotative suction hold with the same hand. And if I need to work, I still have my right hand to cut or to tract or whatever is needed, or to manipulate with a dissector. The only thing that is different is that outside of the surgical field, around my craniotomy, I recreate a kind of nostril with sponges. So I put a lot of wet sponges, to create a kind of nostril to support my endoscope, to support my instruments, to recreate the condition of an endoscopic endonasal technique. So I will show you some cases, because everything has been said before beautifully about the technique, about what you should be careful of. So I will just show you some example. This was a CPA chordoma, not so usual, almost purely intradural, and it was going quite laterally. I didn't want it to go endoscopic endonasally because I thought there was a risk of CSF leak first, and secondly, the control of the sixth nerve would not be very good with coming from the nose. So what I did here is an anterior petrosal approach to have access to most of the tumor. Everything that was above the internal auditory canal could be reached with the microscope without a lot of difficulties. It was a soft tumor, but for the lower aspect of the tumor, in fact, I could not reach it with the microscope, and I used the endoscope. Same technique, the endoscope on the left hand, moving with my fingers the suction, rotative suction, and manipulating with a dissector when it's needed. If you don't need two hands, two working instruments, then you just use your endoscope, your suction on the right hand, but you can move it very easily because it's bended, because it's rotative. And here you see that I had a good control of the sixth nerve, pretty good, in fact. And I could also look anteriorly to get into the clivus. This was a very interesting cases of CPA meningioma. This lady was 70 years old, and this tumor was growing rapidly. It looked on the preoperative MRI, several MRI, it looked like not a very nice meningioma. So I did a retrosig craniotomy. In this case, I'm going to move fast on the microsurgery steps of the surgery. It was a painful case because the tumor was adherent to the cerebellum, to the cranial nerve. It was not a nice meningioma, very soft, but also very adherent. You see the color, this yellow color. I don't like it when it's meningioma. It's usually aggressive tumors. This was a lower cranial nerve. It was also infiltrating a little bit the fascial nerve. There was a tumor all around the fascial nerve, and I had difficulties to take the tumor that was in fact behind the fascial nerve. I used this technique that was that I learned from Fukushima, pushing a cottonoid on the other side of fascial nerve to push the piece of tumor that was in front of fascial nerve up. This is looking with the endoscope at some point because I was lost. I didn't know exactly where I was according to the cranial nerve and foramina of the skull base. And it's typically a case where the endoscope helped me to find my landmark again in this little mess, in fact. Here was a tumor behind fascial, and this is a technique I used to push this tumor that was in front of fascial, pushing it up with this cottonoid and catch the tumor on the opposite side. So at the end, I achieved a quite nice resection, but there was also some tumor into Meckel's cave. And at the end, I am using the endoscope to check the deepest part of the CP angle to check trigeminal nerve. And you see this piece of tumor just above trigeminal nerve. I wanted to achieve not a complete resection because considering this aggressive behavior, I was not expecting a complete resection, but I tried at least to remove as much as possible of tumor to prepare this patient for radiation therapy. So here I am using a curette to look into the porous, not very deep into Meckel's cave. I didn't want it to take any risk for the trigeminal. It was not worth the price because she anyway would need radiation therapy afterwards. This was a little piece of tumor also into the internal auditory canal. So typically here, the endoscope was quite useful to complete my resection and to get oriented. This is a nice petroclival case, very unusual presentation. This patient had a complete 6 at the clinical exam, but she was asymptomatic. She was not complaining of diplopia. This happens when the 6th nerve paralysis is extremely progressive and the patient adjusts mean time. And I saw that a few times. This was the meningioma. A lot of infiltration of the petrous bone. It was going to the sphenoid sinus. So my goal here was to resect as much as possible, but not going into sphenoid sinus because then you have a significant risk of leakage. I will go fast on the video because this is not the purpose of this webinar. I did an anterior petrosal approach. It was most of the tumor was above the internal auditory canal. The epicenter insertion was above the internal auditory canal. And here is the drilling of the petrous apex. I did a resection first of everything that was into the petrous bone, trying not to get into the sphenoid sinus. I go fast, open the dura, resected the tentorium, peeled the tumor from the 3rd nerve, open Meckel's cave, classic petroclival technique. This is 5 into Meckel's cave. I am resecting the tent with those cutting ronger. Here is cutting the tent, posterior cut of the tent towards 4th nerve, that is here. I alternate debulking of the tumor with dissection around the tumor from the brainstem. And when I start to get to the internal auditory canal, I am not comfortable because, and it's one of the issues of the anterior petrosal approach, when the tumor is going down like before, you don't have nice control of what you are doing. And it was exactly the case with 7 and 8 in the cisternal segment. I was manipulating the lower aspect of the tumor and I had some irritation response of the fascial nerve. So here I was in a kind of a difficult situation and at the perfect place to take the endoscope and to look at this piece of tumor that was pushing 7 and 8. The only thing I did was to push away this piece of tumor from 7 and 8. And then I knew that I could eventually, a little bit blindly with the microscope, resect this piece without a fear to track with the tumor to track 7 and 8. So this is a perfect example of the use of the endoscope. Then I put the endoscope also on the more medial aspect at the level of the clivus to coagulate some tumor base here, medial to 5, and here a little bit down on the clivus to coagulate the epicenter, the dural base of this tumor. I think at some point we can see, yeah, this was the 6th nerve. You see that I left some tumor around the entry point of 6, didn't want it to cut the 6th nerve, even if she has a complete 6, it was not worth doing it. This was a case of fascial nerve schwannoma, very unusual case, recurrent after surgery and radiation therapy. She had hopefully a previous hypoglossophacial anastomosis, and so she had a quite good recovery. So here for this tumor, I decided, because you see the tumor is mostly into the petrous bone around the geniculate ganglion, I did a subtemporal approach. Again, I go fast on this. It was a very nice case because it's not so often that you can go through the geniculate ganglion and explore this anatomy without being afraid of the fascial. I did a labyrinthectomy from above to expose, in fact, the jugular foramen from above because the tumor was going down to the jugular foramen. The goal here is to achieve a complete resection because it's a recurrent schwannoma after radiation therapy. So here is drilling of the labyrinth. I go fast to the end where I need to control the lower aspect of my tumor cavity. You see that the tumor is soft, but I want to make sure that I have completely resected the tumor down, going into the jugular foramen. Very unusual view for a subtemporal approach. Here I bring the endoscope inside. Cisternal, in the cistern, nothing special to look at, just checking the cranial nerve for the beauty of this view. And then I am looking into the jugular foramen from above. You see the lower cranial nerve, and then the nerve into the jugular foramen. There was a little piece of tumor on the nerves that I coagulated. I didn't want it to have a lower cranial nerve deficit. And I check at the end the function of the lower cranial nerve with a stimulator. So here also, the endoscope give me some security and allow me also to check at the end if my resection is nice. This was a very unusual case also. Chondrosarcoma, very lateral. Those tumors, those chondrosarcoma, very lateral in my opinion, and it has been shown also are usually more aggressive. But this patient was not a young patient, was 72. He was not necessarily in a fantastic condition. He had a complete 6. And I didn't want it to go on the nasal in a case like this. There is a lot of tumor in the petrous bone, but I thought that going on the nasal, having a CSF leak at the end was too risky for this patient. He was too fragile. So what I did is a retrosig with the idea of putting the endoscope after taking out this piece of tumor in the CP angle to put it into the petrous bone. Here, I had this painful ICA artery that was hiding me from the tumor. And I'm sure Dimitris and Michael and Henry have seen that before. It's not so often, but it was embedded into the dura of the posterior surface of the petrous bone. So I had a hard time to completely mobilize this vessel. So once I have resected the tumor in the CP angle, I am going into the petrous bone, trying to take as much as tumor as possible, again, to prepare this patient for proton beam therapy, which he had after the surgery. I am alternating microscope, endoscope. Here I'm exposing the clivus. Here dissecting the tumor away from the fascial nerve. And at the end, I put again the endoscope into the petrous bone. This is carotid artery into the petrous bone. You see that it's pulsating. So here, neural navigation, you understand that it's very useful, because I have to say I was not completely understanding what I was exactly looking at, and that's where neural navigation can help you. Finally, I tried to reach a piece of tumor in the Meckel's cave. The tumor is soft, so I drill towards Meckel's cave above the internal auditory canal. And at the end, putting this malleable rotative suction into Meckel's cave, I was able to suck this very soft part of the tumor into Meckel's cave. You see that trigeminal nerve is quite nicely decompressed. I'm going to skip this one. It was a chordoma of the jugular foramen, a recurrent one, a tough case because this patient was operated before several times. I did an infralab approach with transposition of the vertebral artery down. Use the endoscope here in the extradural aspect of the tumor. I did the resection with the endoscope, most of it. And so we are extradural, outside and below the jugular foramen. Tumor is soft in chordoma, so it's perfect for endoscopic resection with a strong suction. So I try to clean the surgical field as much as I can. I coagulate the margin of the tumor cavity at the end. And this was the hole here towards the CP angle. I don't know if you saw it, just here. So now I am opening, I'm going to open the dura to have another look intradurally to remove the piece of tumor that was intradural. This is the lower cranial nerve. This patient had a 12, complete 12, and I was just on the outside of this. So here you see my suction coming from the opposite side. This is the 6th nerve here. This is the lower cranial nerve. I'm going to cut 12 in order to take the tumor out from the jugular tubercle. There is some tumor here on the basilar artery, or probably the pica is stuck to the tumor. So here it was done under endoscopic guidance. Same technique. At some point, someone was helping me holding the scope. You see the hole going into the extradural compartment. Separating here this piece of tumor that was bulging into the CP angle below the lower cranial nerve, between lower cranial nerve and the hypoglossal nerve. So I'm separating here the nerve from the tumor, putting here some gel foam because I was going to use the coagulation, and I'm putting gel foam just to protect the nerve from the coagulation. I need more space, so here I cut 12. It's always painful to cut a nerve, but here the patient had a complete 12 for quite a long time, so I was not expecting a recovery. He had some tongue atrophy also. Okay. Vestibular schwannoma, I'm not going to show it because Henry showed beautiful cases. This is just the end of the videos where I am controlling, I am controlling what's inside the internal auditory canal with an endoscope. Nothing very special with it. I am not doing that anymore. I'm not doing that anymore because I have to say that I am not trying to achieve a complete resection deep into the internal auditory canal anymore for big schwannoma. And I have to say that for small one, I am using radiosurgery. This was a third nerve schwannoma that I reached with a posterior Petrosal approach because the tumor was behind carotid artery and perforators. I did a combine. It was very nice to reach and to expose the tumor, transposition of sigmoid and transverse sinus, usual technique from Al-Mefti and from Al-Mefti, transposition of the sinus. Here, cutting the suprapetroid sinus. What I want to show you is the end. Debulking, the tumor was quite soft. And at the end, I was not able to locate the third nerve here. Patient had not a complete third before the surgery, but impossible to find third. And I was quite worried that I cut it. And in fact, yes, I cut it because I could not find it. It was very elongated around the tumor. And in fact, it was a neurofibroma. So in neurofibroma, the nerve fibers are inside the tumor. And I knew that I cut it at the end because I put the endoscope here. And I am looking at the oculomotor foramen, which is right there. And I see a piece of tumor. And this piece of tumor is going into oculomotor foramen because it was an oculomotor schwannoma. This is pituitary stalk here. And I knew that, that I cut the third. So she had a complete third post-op, and she started after a few months rehab of the eye. This was a nice chordoma case, craniocervical junction chordoma, because it was going intradurally tight to the vessel. I decided to go from an anterolateral approach because I was afraid of first having a CSF leak, and secondly, difficulties to completely resect this tumor in a young patient because of adherences with brainstem, like here, and tumor surrounding vessels. So I did an anterolateral approach. This was with an infralabyrinthine approach, opening the jugular foramen because the tumor was going quite high. And if you want to go high with an anterolateral approach in the clivus, you need to transpose digastric and to remove the tip of the mastoid. This is removal here of exposure of the vertebral artery. I go fast on this. Transposition of the vertebral artery. And I am going now to drill the mastoid to expose the jugular foramen, open the jugular foramen, which give me 1 centimeter, even a little bit more of exposure up to the tumor. Without drilling the mastoid, I would not have this kind of view. I am resecting the tumor with the microscope. It's soft, so it's not very difficult. And at some point, I go intradurally to resect the part of the tumor that is going intradural. It was not so difficult under the microscope. And I can completely resect the dura that is infiltrated because I have no fear of CSF leak. And at the end of the surgery, I am putting the endoscope inside to check. And this is the spinal cord from above. It's a quite unusual view. You see the spinal cord in the cervical canal with the nerve. Here it's on the opposite side, just medial to the jugular foramen. I can see this little ball of tumor, little remnant of tumor. Without the endoscope, I don't think I would have found it. And I resected at the end to achieve a complete resection. So here it's a good example of looking in dark corner to find additional tumor. Trigeminal neuralgia, we had fantastic cases from Henry. This was interesting because it was recurrent, operated in another institution, and you see that there is some pieces of Teflon, but the conflict is still here. At the root, the Teflon was very anterior, but the conflict is still here. So here I am completely trying to free the nerve. First, to remove the Teflon that was in contact with the nerve. I didn't resect it because it was a big piece and I was afraid that it was in contact with force close to the free edge. So it's not worth taking it out, but it's important to remove it from 5. Here, that's a conflict. I am pushing away the artery here. Pushing away this little loop. As Henry said, I am always trying to put the Teflon away from the nerve. The Teflon, I think, should not be in contact with the nerve. You have to flip the artery for the artery to find its position. And then you use the Teflon just to hold it, but not between artery and nerve. I don't think it's a good technique. Here, there is another little artery. I am taking it out. It's very small, but you never know. You don't want to have a recurrent trigeminal neuralgia and ask yourself, did I forgot something? So here it's already recurrent. So I really want to clean the nerve. And at the end, I put the endoscope to see anteriorly, because on the MRI you saw that there was a Teflon. It's Teflon. Yeah, it's Teflon next to the nerve, just before the porous. So here I want to check with the endoscope, and I want to free this nerve from the Teflon. I think for MVD, it's as much as important to put the vessel away than free the nerve also. And the nerve is freed by cutting all the arachnoid around it. I think if you cut all the arachnoid around the nerve, you have already done a big part of the job, even if you don't decompress. This was my final case, epidermoid cyst. This lady, 23 years old, 2 previous retrosig approach. She had a fascial not complete on the diplopia following the previous surgery. It was a 6, and she recovered quite well. But then she started to develop symptoms, and in fact, she was very severely impaired when I did the surgery. She was severely hemiparetic with big swallowing issues. And if you look at the MRI, you see that the cyst is completely, there is almost no more brainstem here. It's completely pushed on the other side. There is cavity into the brainstem. And here it's a difficult issue, because how to reach this tumor? Going another time from a retrosig to the surgeon before tried 2 times, and he was not able to achieve a nice resection. So I would definitely not be also able to do that with a retrosig. And in addition to that, you have the scar tissue. You will have to work between 7 and 8 and 5. It will be very difficult. So to me, it's a perfect case for combined Petrosal. This is what I did with a cosmetic mastoidectomy, to have multiple angles to reach this tumor. But I did a mistake. We're on the left side. And in fact, I didn't look careful enough at the venous drainage, especially the temporal lobe venous drainage. And here, I find at the end of my approach that there is a big vein here. Well, this is a Petrosal vein. This is not the issue, but there is a big vein going, temporal vein, Sylvian vein, going into the superior petrosal sinus. And this means that I cannot cut the tent. So I can work above the tent, below the tent, but I cannot really transpose the sigmoid sinus and transverse sinus, which is key for combined Petrosal, because you take advantage for the transposition. Your corridor is given by the transposition, but I cannot free the sinus because I cannot touch the tent. So here, I am quite limited rapidly with my microscope, and then perfect place for the endoscope. I think Henry showed a similar case where previous surgery were done. I could not take away the capsule. You should not try. I did not try because she was already impaired. I didn't want it to add more deficit to what she already had. So you try to take as much as you can to suck the content, to take as much as possible of the capsule anteriorly along the dura, but not along the brainstem. So I think a skull-based surgeon should master the microscope, but also the endoscope. I think it's both equal with different use, but it's both equal. And we need to prepare ourselves to have new visualization tool. Microscope is now, but we don't know what we will have in between our hands in the future. Most likely it will be endoscope or kind of device like this. This is a mix of endoscope, microscope. So we should not stick to a technique. We should be, I think, open, use what the technology gives us, try to push the system as far as possible to take advantage of it, and prepare ourselves and be open-minded to use a new device that will come in the future. Thank you very much. Hello.
Thank you, Sebastian. Great talk and great video as usual, and thank you for all your involvement in the skull-based section. I have received several questions that I will share with you. One question from Oriela Rustemi. The endoscope often allows to view more than you can resect. Could you please give us some tips and tricks to increase the working space and resection? And there was also a question for Dimitris initially from Jacinta Francis. What is the best size for the craniotomy? So maybe you can answer together those questions. How to increase the working space if you would like to resect more than you can view under microscope?
So in terms of the size of the craniotomy, the size of the approach depends on the anatomy of the surgical target, and it depends on the surgical goal. So if it's an endoscope assisted microscopic approach, primarily microscopic with endoscope assistance, then the extent of the approach depends on what we need for the microscopic approach, which most of us agree is what we usually do anyway. So that the concept of minimally invasiveness doesn't really necessarily correspond with the extent of the craniotomy. But if we are talking, if the question is about a fully endoscopic approach, again, it depends on where you're trying to reach and what kind of operation are you doing. If you're doing an MVD, it's a very small approach. If you are trying to address a tumor endoscopically, which most of us seem to agree that it's not a fantastic idea, then it has to be a bigger approach. Now, for an MVD, or let's say a simple fully endoscopic approach, I think a bit less than 2 centimeters is a reasonable extent. I know that there is literature talking about a single burr hole and fitting all the instruments through a single burr hole, but I've never personally been able to do it. And I think Henry mentioned during his talk that if you have a very, very limited approach and a very, very small burr hole, then the movement of the endoscope is very, very restricted, and you tend to try to bypass this by using the endoscope as a lever, and then that tilt motion is not great, it's risky.
One question about navigation assistance with the use of the endoscope. Have you any experience of navigating the instruments or the endoscope? And also one question about the robotic assistance. Any comment?
We have tried a robot, but the robot makes only very simple movements. You can introduce an electrode into the brain like a stereotactic frame, but we have really tried a lot of robots, and sometimes I'm just thought it risky because it's a big industry robot, not specially designed. I think so far what I have seen, it is not ready for use. It's just to place an electrode into the brain for stereotactic purposes, but this can also be done with a stereotactic frame. What I have seen was just very expensive endoscope holders, and I think it's not worthwhile to spend the money for it. But of course, in the future, we will see more miniaturization and probably also good instruments, but so far it's not working well, in neurosurgery at least. Sebastian, what do you think? Will we be replaced by a robot soon?
I hope not, Henry. I just pray that we will not be replaced by robots. No, I'm not convinced with robots in neurosurgery. I think it will come, but not during our lifetime. I don't think so, because I mean, what can happen during a case? There is so much things that can happen, bleeding. I mean, it's not a reproducible surgery, what we do. We need to adjust constantly to the situation. And I don't think robot will be very useful for what we do. Fantastic for stereotaxy and all of this, maybe drilling the bone, because it's the variation are not so much, and it's and there is not so much bleeding, but using a robot to work into the brain, I think it will take time.
Any comment on navigation and endoscope? Because we could use enhanced microscopic view with projection through the microscope. With the endoscope, it is not possible. Do you have any comment or experience?
Not much. What I have used once tried, and I have not seen it since, with the Muller microscope, is picture to picture. You are using the endoscope and you have the image of the endoscope into the microscope. And this is not bad because it gives you the control of the side of the microscope. And I think it was not pushed very far, this technology, but I think there is something to do with this.
Picture in picture.
We have
But
used
it's not on the market anymore. Henry?
No, the picture in picture has a very poor quality, you know. The resolution of this image, what you have from the endoscope inside the ocular, is not good.
Yeah.
So it's much better you look at your large screen, then you have a better differentiation. Color fidelity is better, resolution is better. I have tried with the size, you can also bring it picture in picture into the ocular. There's an image injection of the endoscopic view, but I don't like it. It's not.
I agree with you that the quality is not very good, but I think the technology is interesting. This principle of looking with a kind of microscope to what you are doing with the endoscope. This combination of both, I think, I hope someone will push it more because I think it has some value.
No, I think it's disturbing me, you know, when I have the microscope in front of me and then I have the endoscope and then I should work. How should I do it? All is in my way. So for me, best work, I bring away the microscope, I bring the endoscope in, I have my hands free, I can dissect around. If the microscope is bulky in front of me, I don't like it. That's why maybe in the future, Sebastian, we will have an exoscope which is combined with an endoscope. So you look at one screen and you have the exoscopic image where you can control your instruments, and then you have the endoscopic image on the same screen, at the same screen. That would make sense.
Why not? Why not? Yeah. It's a similar principle. Instead of the microscope, you have an exoscope, but at least you have something that look at what you are doing with the endoscope. I think it's quite nice.
I received many questions. One of the questions is to minimize the damage with the instruments. Have you any experience with hollow sleeves, for instance?
What do the sleeves? I did not get it. What is it?
Sleeve meaning some protection, and you go inside the protection with your instruments, a canal, creating a canal with the sleeve.
Oh, then you cannot work by manually. This is what we do in intraventricular endoscopy. We have a channel endoscope and we have protected the brain around it, but we have a very coaxial working. For microsurgery at the skull base, you know, this coaxial working should be a little bit reduced and it is easier. If you are a master like Sebastian and you have the chopsticks technique, then it can be done. But I like to have two forceps. I want to keep the tumor and then I dissect the arachnoid plane with two hands. For me, that is the least traumatic way to dissect a tumor away from a nerve or an artery.
But by simple plastic sleeve, in which you are only placing your instrument to protect the structure surrounding the instrument, you can have different channels. I have already seen one sample of plastic sleeve to protect the structure surrounding, with one channel for the endoscope and another channel for the instrument. Have you had any experience? No?
No, where do you want to fix the sleeve? No. I think it makes sense when you go through into the ventricle and you go in and out with an instrument. But if you have a skull-based case, there is just, well, where do you want to fix the sleeve? If the sleeve is around the instrument, you can also touch the nerve and damage it.
I think the question is about some kind of mobile sleeve, very protection of the instrument, but
I don't know.
No experience.
I think that might come in the future. If you see Sebastian's presentation with the end effectors, that is something that we may expect in the future in terms of soft robotics or end effectors. But again, it would be very complex in skull-based surgery. As Sebastian said, it's so unpredictable sometimes. Because otherwise, unless through a sheath, the instruments can go wider, we'll have the problem that Henry mentioned with coaxial working, which we have in intraventricular surgery. But there are different applications, and you have to have task-specifically designed instrument. So I have no experience in this, and I can't imagine how it works.
You mentioned also the problem with the heat related to the light source. I received one question about the light source that you are using, xenon or LED?
I prefer xenon because the color resembles more the sunlight. We can also use LEDs, that is true, but I prefer to have xenon light still. But it becomes more hot, I guess. Yeah, that's true, than LED.
Maybe a final question for Sébastien. Someone would like that you remember how to protect the fourth nerve when you are cutting the tentorium.
I usually push just before reaching the free edge. I push a little piece of Surgicel or cotonoid, because the fourth nerve is embedded in the arachnoid, and when you cut the free edge, you are in fact in the subdural space. So I push a little bit of Surgicel or cotonoid to push the force away from the free edge, and then I cut it. And the reason also why I do that, it's because when you cut the free edge, it's usually bleeding. And I think force is also quite often injured by heat instead of just direct cutting. So I protect I put it away. Like this, I can coagulate without a risk of heat for force.
Thank you, Sébastien. It's time, I think, to finish. I would like to thank you, Dimitris, Henri, Sébastien, for this great webinar. I see with the comments that it was highly appreciated. Thank you, Anna and the NS office, for your support and the organization of the webinars. It's my pleasure to give you another appointment for the next webinar organized by the ENS skill-based section. And on November 18, we will have great talks again on petroclival meningiomas. It will be great to meet you again on November 18. So I wish you a nice evening and see you soon for those very interesting ENS webinars. Thank you so much. Bye-bye, and thank you.
Thanks
Thanks
for invitation. Stay safe, everybody.
Stay safe.
Bye-bye.
Bye.
Bye-bye. Bye-bye.